Thank you. Hi, everybody. I'm Alyssa Abo, and it is my honor to be here today to talk about point-of-care ultrasound, and specifically, I'm going to talk about education and the education system that we have for pediatrics at my institution, and also what we are doing back in the United States for point-of-care ultrasound for pediatrics in general. Thank you, everybody, for having me. When I think about point-of-care ultrasound over the last 10 years, we first started with education, and we had a lot of teaching to do. From that point, we realized education was just the beginning. We then were focused on workflow, meaning that once the images were obtained, we had to do something with them. In order to have impact beyond the hospital, beyond our institution, we wrote policy statements to help other people throughout the country start their programs. Now we are trying to incorporate point-of-care ultrasound with simulation. And in order to have impact beyond and have a bigger reach, we are now seeing more point-of-care ultrasound in global health. I like to think about ultrasound as an ecosystem. And this is true no matter what specialty you are in. Who here is emergency medicine? Can you show me? Okay. And critical care? And some trauma surgeons? Okay. Anesthesia? No? Pediatrics? Okay, great. Anybody else? Did I miss anyone? Okay, good. So the first step is to determine the scope of practice. What are you using ultrasound for? Then the next step is to determine what equipment you need. In pediatrics, we often use different probes than they do in the adult emergency department. Then we focus on education and training, and from that point we can talk about credentialing. The next step is to then take the images and store them somewhere, and that allows us to have a quality assurance program, a way that we can ensure that point-of-care ultrasound is done with quality. And if all of those steps are completed, then in the United States, we are able to bill and charge a fee to the insurance companies for the procedure. So the objectives today are to focus on the education, the training, and the credentialing. So just a quick overview. In the early 2000s, the American College of Emergency Physicians wrote a policy statement for point-of-care ultrasound. This document is very helpful for us in pediatrics and others in other fields because it's a good reference on how to start training in point-of-care ultrasound. And this document has been updated several times over the last 15 years. Next, the AIUM, or the American Institute for Ultrasound and Medicine, similar to the Korean society that you have, started a campaign called Ultrasound First. They wanted everybody to think about using ultrasound first because the thought was it improves the quality, it's safe, and it makes what we do more efficient. And that obviously is beneficial to the children. So from all of these different initiatives and documents, we needed to write something specific to pediatrics. So in 2015, we wrote a policy statement and technical report on how to use point-of-care ultrasound in pediatric emergency medicine. The next step, and this is a great resource, and I'm happy to send any of these documents to anybody who is here, but this is a standard reporting guideline. It goes through many indications and suggests what to look for and then what to document. And so if you would like to look at this, it's essentially a summary of the evidence. But there was a piece of the puzzle that was missing. And so the next document that's coming out soon is one that it took us a few years to write, and it's Credentialing Pediatric Emergency Medicine Faculty in POCUS. And that's what we will talk about today. So what are the steps to credentialing? And even though I've only been in Seoul for 2 weeks, and I will be here for 2 years, I went to a temple, and it was beautiful, and it was a perfect picture to show you the next steps. So next steps. First, you need the education. Then you need a way to ensure that the education was good. That's what we call the competency assessment. And from that, we can do the credentialing. Definitions are very important, and they sometimes get confusing. So competency is talking about the individual. It means that the person who you are trying to teach understands the indications for point-of-care ultrasound, that they have the technical skill to acquire the images so they know how to work the machine. They are able to look at the images on the screen and interpret them. And then lastly, they're able to take their new knowledge and integrate that into the care of their patient. That is being competent. Credentialing refers to the process. It happens usually at the hospital level, and it's what we say physicians need in order to do anything. So we have to be credentialed in intubation to intubate. Likewise, we have to be credentialed in point-of-care ultrasound to make decisions. Certification is a little bit different. Certification comes from another party, an outside organization usually. We don't have any certification right now for pediatric POCUS, and it's not necessary to be credentialed in the hospital to have a certification. So what are the pathways to being credentialed? There are two. There's a training-based pathway, and there's a practice-based pathway. The difference, training happens when you're a resident or a fellow, and practice happens when you are in practice as an attending or staff physician. At the center is education. We encourage everyone to have a curriculum. In the curriculum, it says what is your scope, what applications you want to be teaching, and you have goals and objectives for the learner. In the document that we are about to publish, we broke it down into two, basic and advanced. And you can see that there are ones in bold. Bladder, cardiac, fast, soft tissue, and vascular access. And these are the 5 that we believe every physician in the pediatric emergency department should know. Now, there are different ways to teach, and we know that. Sometimes we use didactics. Sometimes we encourage asynchronous learning. And then we also have experiential learning, which is the hands-on scanning, and we will talk about them. So didactics, it can be a lecture, it can be a 2-day course, or even a webinar. And it's like this. Someone is teaching to a group, usually at a very set time. The challenge, even with the webinars, is that that time is not always convenient for everybody. So we have moved on a bit, and now we encourage a lot of asynchronous learning, where people can go by themselves when the time is good for them and sit in front of a computer and practice and learn. We call FOMED the free access, online, open or online access to medical education. There is a lot of material, as I'm sure you know, on YouTube and different websites, that a lot of the learning can be done there, and a lot of the work has already been done. The hands-on issue is obviously a challenge, because hands-on scanning is the most important way to teach and the most important way to learn. And there's this balance between supervised scanning, where an expert is with the person learning, and then independent scanning, where people go and they learn by themselves. The challenge is the hands-on scanning can be very resource intensive, meaning that oftentimes hospitals only have 1 or 2 people who are experts, so it's very hard to spend time scanning and teaching people at the bedside. In addition, it takes a lot of scanning in order to see the pathology, to see what's abnormal. This is where sometimes having partnerships can be very helpful. We encourage a lot of times the pediatric doctors to go to the adult emergency department or spend time with radiologists or cardiologists and learn in their environment, because it's helpful to see ultrasound in many places and also see the pathology that other people are seeing. Beyond that, we have innovative education. So forward thinking about what are other ways to educate. We are using a lot of simulation. So SonoSim, I know you're familiar, is an example where the person can be at the computer by themselves using this probe and getting used to the direction and the way that things move. Other types of simulation, there are stickers that you can put on a mannequin or on a child model, and you can practice, and you can build cases in the computer, and you can encourage people to learn something specific. And then there are other types of mannequins that you can actually ultrasound. And then if you find that there's fluid around the heart, these mannequins, you're allowed to put a needle inside and drain the fluid. So there are many ways to learn independently. So once the training person, whether it's a trainee or the person who's learning, once the learner is completed the education, the next step is to determine if they really understand what they need to. And that's what we call the competency assessment. So there are different ways that we assess competency. We use numerical benchmarks, written examinations, and observing someone's performance. And you can use any of these or a combination of all three. And maybe there's even more that you use at your institution. As far as numerical benchmarks, that's saying in order to do the FAST exam, we suggest that you do 25. But the problem with that is that we know not everybody learns based on the same number. So one person may do a FAST exam 10 times, and one person may need to do it 50 to really understand. So coming up with the perfect number is very challenging. There was a nice study done a few years ago, and it basically said simulation is a good way to help assess competency. And in addition, the study highlights that the volume of scans that you do by itself is not sufficient. So we can't just rely on a number. We need to have people do a certain number and then figure out another way to know that they are competent. So once these things are completed, then we talk about credentialing. So credentialing means that the educational objectives have been met. Whatever numerical benchmarks you decide have been completed. The way in which you assess competency has been completed. And then the last piece, which we have not talked about before, is the documentation. In order for the physicians at our institution to be credentialed, they also need to know the proper way to document what they find in the medical record. So that's the last piece. And all our algorithm looks something like this, and I can send this to anybody who's trying to build this type of program. But all it means is that on one side, we have the individuals who want to be credentialed, who learned in training. On the other side, we have individuals who want to be credentialed, who are learning as staff physicians. And then down here in the corner, once you've completed that, we need to ensure that people are learning and they're still performing ultrasound, so we have a maintenance of competency, and we are following everybody every 6 months to 1 year to ensure that people are really using the ultrasound machine, because we know if you don't use it, you will lose your skill. So in conclusion, education is the foundation, competency assesses the individual, and credentialing establishes the process, and we just take it one step at a time. Thank you very much, everybody, for having me. As many of you know, I am here in Seoul with my husband and my family for 2 years, so I hope to get to know many of you and collaborate with you. I've put up my contact information, so please feel free to reach out to me. And if you have any questions, I am happy to take them now. Thank you.
Thank you very much.